Health literacy, does it actually exist? Well, it does exist in academic journals, it exists in media, exists in health policy, but it doesn't really exist as a commodity in any person's life. It's just an idea, it's just a theory perhaps. But what health literacy is, how has it been operationalised beyond the academic rhetoric? Can it provide insight into quality care? Can it drive practitioner and system improvement? And can it be used to reduce health inequalities? And it's that last point which really drives me, is how can we get deep insight into the communities about why is there health inequalities, and can we engage in some mechanisms to do change? Health literacy is everywhere. It's in big policy and publications in the US, it's in publications and press releases in Asia, it's in very strong, clear documents in the US, and the European WHO office has released this document here, Health Literacy, the Solid Facts. And more locally, we have Making It Easy from Scotland, an outstanding document to support local practitioners and policymakers and managers to get on with doing something. And this is a great piece of work by Graham, who will be from Scotland. Thank you for providing this for us. But I need to give you some sort of definition of what health literacy is. It's the ability to understand, access and use health information. It could include social and cognitive skills to do these tasks, motivation and engagement in health promoting and disease management activities. So that's a reasonable definition. There's about 18 definitions, or probably 19, given there's been another few hundred publications on health literacy in the last couple of months. I don't really mind which definition people use, but in all the definitions, there's something about understanding, access and using health services. Really important point about a lot of literature you'll read, which so far the country producing most literature is from the US. In the US, it's been mainly about risk mitigation, about reading and writing and numeracy. In the States, it's moving away from that gradually with a lot of community programs. But here in Europe and in Australia, there's a very strong emphasis on health literacy being about equity and rights, moving into the health promotion and the public health scene, rather than just restricted to the medical scene, where it's about reading and writing and risk mitigation, and risk mitigation in part from the clinician's perspective about getting sued, not necessarily risk mitigation from the patient's perspective of getting prescribed the wrong treatment. A little bit of history. In the 1960s, the concept of functional health literacy defined in education, paving the way for different literacies, like computer literacy. The term health literacy first applied in 1974. Then in the 1980s, debates about the definition began. 1990s, the first generation of tools were generated, and so lots of the research you'll read come from that part of the world, that part of the era. And then 2000s, there was causal models and interventions began to be thought about, and more recently, 2007 onwards, there's been a many times increase in number of publications, but still mainly based on this reading and writing and numeracy aspect. Given these tools, many association studies have been done. Association studies mean just that, they're associated. You can't really draw substantive causal links between whatever health literacy is, as you've defined it or measured it, and the outcomes. Nonetheless, health literacy has been clearly showed in association studies to be associated with increased hospital admissions and readmissions, poorer medication adherence and increased adverse medication events, less participation in preventative activities, higher prevalence of health risk actions, and I can go on, just the typical sort of things which in fact, in many ways, education and other basic skills have been associated with, right through to being increased mortality, indeed, with health literacy, but association studies. Where does health literacy fit in? There's all these other terms out there, and a lot of these were very familiar for you. So is health literacy something new? Is it coming to try to replace something? What I want to convey today, it's not about replacing any of these, but perhaps getting back to roots about who we're trying to look after here in our communities. What is the purpose of our health services? What is the real engagement there we want to have between our communities and our healthcare system, our health and social care systems? So today we could take a narrower approach to what health literacy is, which is research-orientated, uses the literal concept of literacy, and focused on precise definition of the construct and distinguish it from other precise psychometric constructs like patient activation. You could take that, but I really invite you to consider taking health literacy as a broad approach. It's practical. Let's use a practical orientated approach using metaphorical concept of the literacy like computer literacy and other sort of literacies, and focused on being inclusive and identifying all factors that require for people to make effective decisions on matters that affect their health. So we're going broad. There's a critical concept I need to introduce you to, and that's that health literacy is about the individuals, the client, the patients, their skills. It's also about their environment. It's about the demands and the complexity. The WHO Office for WHO have this nice little statement in our Solid Facts book. For example, during the first few years of living with a chronic illness, people often demonstrate large increases in knowledge and health issues and health services, and small increases in health literacy because their need for knowledge increases almost as fast as their knowledge. Health literacy changes. So individual health literacy abilities, we've talked about them, they're pretty obvious. Literacy skills, verbal interaction, blah-de-blah. Individual characteristics that affect interaction with healthcare system, social support, culture, race, a lot of very important background issues. And then contextual factors that influence the individual's health literacy requirements needed in health and care and public health. Here we have issues around healthcare professionals' interactional skills, the complexity of individual clinical condition, healthcare professionals' assumption that individual has high-level skills and resources to promote communication, self-efficacy and activation, emphasis on individual rather than socioeconomic determinants of health, such as education, income, and competing and complex messages about what is healthy and safe. This is great thinking by Pasha Orlo, really clever thinking. I really enjoy this author's work, really thinking carefully about this. So contextual is so important about this whole business of health literacy. But a note here, the worse the health system is, the higher a person's health literacy needs to be. I've just spent a week in Slovakia, and I was taken to one of their great hospitals, a brand new hospital, as good as anything in Europe, but I was also taken to another hospital, which was not like that at all. And here's some really challenging stories, but I'm sure there's no challenging stories like that here in the UK with the healthcare system. Also visiting in Roma communities to see what are the challenges there. Really interesting work, and very in-depth work will be starting there soon, already ongoing. There's this concept of a health literate hospital too, very interesting. There's all these issues around leadership and a health literate organisation is engaging in leadership around issues, plans and evaluates and improves, prepares workforce, ensures easy access, communicates effectively, explains coverage and costs, quite US focused, target high risk, designs easy to use materials, meets everyone's needs, and includes consumers. All important issues. But this is a tricky one here, the needs. If you want to make sure that your healthcare system meets the needs of your population, but you have to understand these needs first. And this is where the rubber hits the road. This is really where it's going to be really tricky. If we don't understand needs, how can we respond to those needs? Later on, I'm going to talk about if you want to develop an intervention, you really need to start with the needs of the people you intend to serve. If you don't inform your intervention based on the needs, you might be extremely missing the point, missing serving your people. So just quickly now, how has health literacy been measured? I won't go through this in very much detail at all. There's tools called the Rapid Estimate of Adult Learning and Medicine, the Test of Functional Health Literacy in Adults, Newest Vital Sign. There's been audits done. People walking around the hospital can't find how to get their kidneys sorted out because they don't realise the nephrology department is linked to kidneys. That's fair enough. And national literacy surveys suggesting different levels of health literacy. And there's a range of modern scales I'll cover shortly. A lot of the studies have been used using these particular tools. This one's the realm, increasing difficulty of items in a question, in a person's asked to read these out. If they can pronounce them correctly, correctly, they get a point towards their health literacy. They don't need to know what the words mean. The TOEFL, this is a medication label. A person's asked a range of questions, and there's numeracy questions as well around this, literacy questions. This is the newest vital sign. This is an ice cream label. A person's asked a variety of questions. Here's one of them. If you eat the entire container, how many calories will you eat? I'm dyslexic. I'd freak out seeing these sort of things. Apparently it's 1,000. But some people answer they don't eat ice cream, which is quite a reasonable thing to answer, I think. Maybe not in England. So we used these tools to check them out because there was nothing else around in 2009. And what we found with the realm is about 13% of people were classified as low health literacy. With the TOEFL, 7%. With the NVS, 25%. And this is a population-based study, all per interview. Went to great trouble to go to rural and regional and city, rich and poor, and to get proper representation. And then there was a national survey linked to literacy, and it told us we had 60% of people had low health literacy. And really, when I go to a policymaker and say, let's do some work on health literacy, and I show them these results, they show me the door. Come back when you know what you're talking about. I was involved also with the European Health Literacy Survey, the development of that towards the end. And here you can see there's classification of various countries in Europe about the proportion of people reporting or reported to have inadequate health literacy through to excellent health literacy. This work here is suggesting that at the top of the list is Netherlands. They have the highest health literacy. At the bottom is Bulgaria. And Austria just above Bulgaria, which is a bit shocking, particularly shocking to the Austrians. So these questionnaires developed out of a particular framework, particular set of theoretical principles, and it suggests to us there's different levels of high and low health literacy. I'm going to challenge the concept today that there's no such thing as high and low health literacy. We have to be really careful with this concept. So please sit with that for a bit. So what can we do about low health literacy, and where does health literacy fit in? So there's another lovely diagram by Pasha Orlu. So we have a range of issues here about race, education, age, health literacy in the middle here, driven by occupation, employment, and vision, hearing, capabilities. We have access and utilisation of health services, provider-patient interactions, and self-care. With health literacy, these can be driven. It's a nice framework. Thinking about the causes. At the end of it, you'll have health outcomes if all these things are met and supported. This kind of makes sense to a lot of people in the front line. We've been thinking about this a bit more, and we think there needs to be another thing here at the bottom. Participating in health discussions and decision-making may also really help us understand the breadth of things that we could think about if we wish to intervene to improve health outcomes. I'm providing background here, understand background conceptual ideas so that we get to a good position. Well, how can we intervene at the individual and the community and the health services levels for good outcomes, for health and equity outcomes? But really, patient-centred care cannot be properly achieved without health literacy, could it? So how can you possibly have a good conversation with a healthcare professional if you don't speak that language, or you don't have a sense of that's okay even to ask a question? There's a whole range of things here which are important for trying to achieve patient-centred care. What's the most important thing in determining health equity and outcomes? This is a very big question now I'm going to pose. Is it the health literacy of individuals the most important here, or is it the health literacy of the person in the family who cares for domestic issues like buying and cooking food? Or is it the average health literacy of people in a family, or the average health literacy of the individual's peer group, or the health literacy of the highest status person in the individual's age group, who you go down to the pub with perhaps? Health literacy of the village leader, health literacy of health leaders, as in health volunteers. All these things can add up to help determine what might be the strongest impact on health literacy and equity. Or is it the health literacy responsiveness of the healthcare organisation? One thing we're trying to think about, irrespective of the health literacy or the competency of an individual, how can we orientate our services such that, irrespective of their skills and competencies, our health services can accommodate to them? That's what we're trying to think about. In trying to deal with this, and Roy Betterham's a senior fellow of my team. He's an amazing thinker. He's our resident polymath, we call him. And he's been an evaluator of hundreds of programs, really. So he's got to see an enormous range of things that do and don't work. And when you're in all levels of the healthcare system at the very intimate things with all kinds of people from different diseases up to management strategic planning, you get to see a lot of the world. I won't go through this in too much detail, but there's a whole range of filters out there which stop people even getting access initially in the community. They can't even approach, they're excluded. If they're accepted into services, they don't attend. There's all kinds of reasons our services exclude them then. When they receive services or they're in participating in relevant programs or services, and when the services respond to their needs, and very few people get down here to the end, actually get the full set of services equitably and all of their needs met. Our services are quietly excluding a lot of people in many ways for getting services. So there's a bit of a thinking around here. These are some structures, we call this our health literacy access framework, are the things, systematic things which we often don't see that have crept into the system that exclude people from engaging. There's a whole range of things here about how the problem's seen, the particular filters and other filters that give us insight into why our organisations perhaps aren't and can't be health literate or meet the needs of communities. So some multidimensional health literacy tools. I want to run through not all of these. So part of our experience in developing questionnaires, I actually got into this field because I was evaluating something like the Expert Patients Program in Australia, trying to understand this self-efficacy thing, this measure of self-efficacy. So I developed a questionnaire from the patient's perspective called the Health Education Impact Questionnaire, really designed it to really give us a detailed insight on the patient's experience, and also at the same time to really inform the clinical groups and the services about how well they're doing of meeting the patient's needs. And we just focused on that, and it got taken up very widely and very quickly because it serves the needs of multiple stakeholders, and it comes from the hearts and minds of clients. I did this for influenza and orthopaedic waiting list reform, on all these other areas. I developed these questionnaires because I got really annoyed because I couldn't understand what people were going on about, and the questionnaires, I couldn't understand the questions myself. And I thought it immoral to give questionnaires to patients which couldn't understand it, certainly if I couldn't understand it. The influenza, we're very serious about measurement. I hate measurement. I have to do it because I can't work out what I'm going to do as a scientist in my academic life. I can't work out how to improve a program. I don't know whether the program works. So our influenza questionnaire has become really popular. It actually makes decisions for global pharmaceutical companies. It's used globally to make billion-dollar decisions. When your questionnaire is going to make a billion-dollar decision, you've got to be pretty sure it's right. But equally, if your questionnaire is going to inform a clinical decision by a clinician, it's got to be right. People's lives are at stake. So we treat measurement and developing measurement and the validation as a life and death issue. If my flu question doesn't work and one of the big companies decides they don't like me, I'm gone. Interesting, isn't it? So there's a different ways of looking at measurement and the validation, which is very weak in most settings. I won't go into a soapbox like that. So what is health literacy from the patient's perspective? How can we find this out? There's this lovely quote, or this piece of philosophy from a Danish philosopher, Søren Kierkegaard. If one is truly to succeed in leading a person to a specific place, one must first and foremost take care to find him where he is and begin there. That's a deep grounded philosophy of all our work. That's where we start. In fact, at times I'll ensure that my students and staff don't read the literature before we start a research project, because I want them to be freed up from theory, freed up to listen and hear and smell what's going on in the healthcare environment and with the clients they're seeking to understand. To do this, we use a process called concept mapping. It's a very structured workshop, and we consult with patients, the most vulnerable. We've done this with people with ABI, people who are blind, deaf, many kinds of people in the hills in Thailand through to the big cities. I've done this at Tricia Greenhill's department here in London. And that was one of the most toughest I've ever done with those crazy academics. That was tough. But it starts with health literacy in this particular setting with a seeding statement. Now, this seeding statement comes from that very broad definition of the WHO. Thinking about your experiences and trying to look after your health or the health of your family, what abilities does a person need to have to be able to get and use all the information they need? It's just a statement, isn't it? It embodies the WHO definition about understanding, access, engaging in healthcare, but there's no jargon there. And when we ask this statement in a very egalitarian environment, a very safe environment, people say for themselves what this statement embodies from, what's in their own lives. And this is what people came up with. 9 separate different things fell out of this. The researchers are over there. The process of grounded research is happening, and these are the separate ideas that bubbled up. We went into a lot of trouble not to put our academic lens on this. So I want you to think about 2 things as I present this. Think about each of these dimensions as the patient's world, the patient's competencies, but also their lived experience of engaging with health services. So try to think of these 2 things at once. So feeling understood and supported by a healthcare provider. And there's an example question here. I can rely on at least one healthcare provider. The second dimension, having sufficient information to manage my health. Very patient-centered, isn't it? I'm sure I have all the information I need to manage my health. Example question. Actively managing my health. I spend quite a lot of time actively managing my health. That's very patient-centered. Social support for health. I have at least one person who can come to medical appointments with me. Appraisal of health information. When I see new information about health, I check up on whether it's true or not. Over here, a different set of scales, or difficulty scales. Ability to actively engage with healthcare providers. That's deeply reflective of their environment, but also their own skills, isn't it? How easy or hard is it for you to discuss things with a healthcare provider until you understand all you need to? Number 7, navigating the healthcare system. Decide which healthcare provider you need to see. Tough question. Ability to find good health information. Get health information in words you understand. And number 9, understand health information well enough to know what to do. Is that a great name for a scale and a questionnaire? It's so long and so atypical for academia. Here's one of the statements. Understand what healthcare providers are asking you to do. All these come from the hearts and minds of ordinary people in communities. They're not come from theory. It's what they just said in this very safe, normal group environment. I've had some feedback on these from frontline clinicians early on because we did a whole lot of consultation. In fact, our first version, the Helms, ended up being not a waste of time. I was interrogated for 3 hours by the Welsh Public Health, Mansell Ellard. They hammered us. The first questionnaire just wasn't good enough. So we threw it away and spent 2 or 3 more years developing this because it wasn't going to meet the needs of frontline practitioners and policymakers, and it wasn't good enough for clients either, and it was too much sensitive to only very bad health states. So feedback from frontline clinicians in this one, Richard, these are the 9 things doctors hate most about their patients. I was a bit affronted when I first heard this. Thought, oh, you want me to leave now? But no, we're onto something. Here's another one. These describe the heart sink patient. This comes from Trish Greenhold when I first introduced it to her. Oh, really? So you imagine a person walking in the clinic with low score on all of these. Oh, your heart's going to sink because this is really tough stuff. There's a nice history about that. And just one more. Oh, these are ordinary questions. And I thought, oh, this clinician who's in the front line doesn't like these questions. But no, these just ordinary questions about ordinary people. Great. And that's, in fact, one of the biggest compliments I've had in my career. About these 44 questions are just ordinary. Made it. Okay. So it's a questionnaire. It's just a bloody questionnaire, to use an Australian expression. And for some reason, it's been downloaded over 17,000 times. There's huge interest in this. And it's got only 5 items, 4 or 5 items per scale, and they're highly reliable. Each of the scales are tapping onto common mechanisms in a person's world. When we put this through the toughest tests in psychometrics, we have 9 separate crisp dimensions. And when we translate to German, Danish, and Dutch, we get the same pattern. No cross-loadings. No other questionnaire in the world can ever be translated and not have cross-loadings. These ideas are independent ideas in these 4 cultures so far, and there's another 10 cultures coming our way. This is really important. It's really important because we're getting a sense of the integrity of these concepts in humans trying to engage in the Western healthcare worlds. So let's try to get a bit more practical now. What is the use of this? This is perhaps an organisation of the dimensions into a patient feedback sheet. So, okay, here is a setup where the figure of a person is the norm, it's the average for the community. And let's say down here there's the person's scoring higher. The cross is on the other side, so the person's scoring higher. So we could say, Mrs. Jones, you seem to know how to find your way around the health service. Very good. This is on the dimension of navigating the healthcare system. And here we have 2 other dimensions on actively managing my health and deciding what information I should trust. Mrs. Jones, is it right that you seem to have some trouble being motivated? Why is this? Is working out what information to trust a problem for you? So clinicians are bringing this to us as a starting point for conversations. We got this idea with our other questionnaires that these are normal questions and they can start really good conversations for us in our clinical environment. When you get fidelity, when you get engagement and pull from the frontline clinicians, you begin to think you're onto something. Let's go further. Let's go way up now into the population health level. So the questionnaire, 2 of the dimensions were administered in the Danish population health survey to 29,000 residents. 2 scales we used: understanding health information well enough to know what to do, and ability to actively engage with healthcare professionals. Findings: men are better at engaging in Denmark, engaging in health with healthcare professionals. Older people have less skills. Lower systemic status, lower systemic position associated with lower health literacy, but enormous differences seen by education. We're seeing really big distinguishing differences between groups now, as we haven't seen before. And this is completely independent of other known confounders, proper epidemiology this time. Other current work, the role of multimorbidity, regional differences, linkages to health services utilisation. We've got this fantastic linkage opportunity. Regional differences in quality of service provision. Let's see where our hospital rates, our region rates for our ability to engage with patients. Is the information different here to somewhere else? And this begins our thinking about service variation and trying to find excellence and promulgating that. Or the opposite, where do we need to do some support and training? Or where are people troubled the most because of education in other regions and need to invest more in training and support for the clinicians and services in those regions? So coming back to this, patients enter our organisation with quite low trust in information. What can we do to ensure this need is met? So it can be like a thermometer. Or if you're doing a quality improvement program and a pre and post, this could be represented like a change. Okay, we've done well. We've improved our patients' experience in navigating a healthcare service. So it can be used like that as well. But now I need to go higher and higher in a way. So we have a gentleman here with diabetes, and a bit of a turn in your thinking here. So I want to think about health literacy as a community asset. So this gentleman remembers to do things when they're built into his routines. He likes traditional healthy food, trusts his doctor, and he's willing to visit her regularly. He's got a stable and supportive family. Grandchildren are doing well at school and learning about health, so he hears about health upward pressure. There's a growing healthy foods champion in the village. 3 really long-term community health staff with great knowledge of the community. And a friend who has had diabetes for a long time is willing to chat with him. So if you think about some people in our communities do not have much opportunity for intervention on a daily basis, but there's all sorts of assets around them which can profoundly, the only way to perhaps influence them. We do a lot of work across different Asian countries, and we really have to think about these kind of models. And we have many, many immigrants from different cultures here in England as well. We have to think about health literacy as an asset as well. So health literacy, where is it fitting in? I've been sort of asked by Adrian to consider this to a certain degree. So particularly Roy Badderham has built this way of thinking about it. So over here we've got the compliance emphasis in health literacy, which is perhaps one pole. The other end, we've got empowerment emphasis, health literacy distributed in social networks, and health literacy as an individual characteristic. So perhaps enhancing compliance is situated over here, as well as patient education, and a risk model of health literacy is somewhere between compliance emphasis and health literacy as an individual characteristic. Family carer monitoring between compliance and health literacy distributed in social networks. Community action, this is the critical health literacy, but the support that's endemic in your community or in your village. Asset model of health literacy in the same kind of idea. And perhaps patient activation is somewhere down here between health literacy, individual characteristic, and empowerment. So we're trying to be very inclusive here. We're not trying to compete with any model. Health literacy is embedded across all these things, we think, trying to seek to use health literacy to inform us. If we're going to do an intervention to actually be embeddable and useful, we need to fit in with what's already out there. And this is the basis of a grant that we wrote towards the Australian Research Council. And unfortunately, I don't have the logo on here. It's also supported strongly by my university in partnership with Monash University as well, so it's recorded at least. We sought to really develop a way of using health literacy to understand communities' needs and then support the development of interventions to meet those needs using absolute best practice in implementation science, but also, before that, best practice in intervention development. We're not seeking to do a project, we're not seeking to do a program, we're actually seeking, in partnership with our state government, for a health literacy response framework for the entire state. In fact, this idea came when we went to a senior policymaker, Janine, in our state government, and said, "Hey, Janine, nice to see you again. I'd helped her out with some thinking about some earlier stuff. Got this tool, what do you think? Do you think it could be useful?" And she was in our HAC program, our Home and Community Care program, a budget nearly $500 million per year in our state of Victoria, which is about 5 million people, and seeking to really improve health services by making community active. That was part of the model. But our practitioners, our basic practitioners, may not actually understand the people they're trying to serve. Maybe there's a gap in our practitioners or our health workers who aren't actually formal, don't actually understand people well enough to actually implement this model, to actually prescribe the right services. Okay, Janine got excited, and so together we've co-created over a series of years a great partnership and the model I'm about to present. And it's about intervention development. And no one in the room, I expect, has ever studied done a master's in intervention development. Isn't public health important? Shouldn't we know how to develop interventions? You can't study it in here, it's ridiculous. A Dutch group have organised this framework called the intervention mapping, and it starts with a needs assessment. After that, you have the materials to develop intervention which might be useful, which might be implementable, which might have the impact you intend. But if you get this first step wrong, everything else isn't going to be particularly right, is it? So we've put this, it's founded on 3 kind of key areas of intervention mapping, as I just mentioned, the quality improvement collaboratives, and realist evaluation thinking, which is what works, under what circumstances and why, and trying to get really clear what are the mechanisms that are causing things along the way. Understanding differences across services, differences across practitioners, and harnessing that difference to develop sensible interventions. So considering the 9 dimensions of this health literacy questionnaire I mentioned before, there's potentially thousands of strategies that are or can be used by health workers in direct contact with patients. These impact on one or more of these health literacy interventions in some way. So what we've done is we've administered this questionnaire to across 9 organisations. Each of them have collected at least 100 of these and the target group they want to work in to develop their own interventions. This is a cluster analysis. This is an analysis of the 100 cases of the typical clients the practitioners are using on a daily basis or working with on a daily basis. And there's just different subgroups of people in your community. So clinicians get to see these are the different subgroups. And we can take these subgroups and convert them into a clinical vignette. If I convert them to means across these dimensions, it would be meaningless. But let's convert these means into a story, a typical clinical story. Giovanni is a 73-year-old Italian man whose wife died 3 years ago, and then it describes this person's characteristics given their health literacy profile. We do qualitative interviews to make sure the context is exactly right as well. Here's another vignette. A different set of skills, different set of characteristics, but actually they'd have the same average health literacy, but as a clinician, as a public health person, I would respond very differently to these people because they have very, very different characteristics. Therefore, we need to tailor our services. But what we have here, because of this work here, we've actually seen this full profile of different kinds of people in this organisation. Then we do something really interesting. We ask frontline practitioners, do you see this kind of person coming into your clinic? And invariably say, oh, yes. Actually, someone in North Manchester said, oh, that describes me. Except I got a boy and a girl, not two girls, with one of the vignettes. And that was from her data, from the patients that they had collected in North Manchester. So when we ask, well, what do you do with people like this on a daily basis? How do you enable them the best way to get the most out of their health? And they tell us very enthusiastically. Actually, sometimes they're really bored because we're just asking them to tell us, what do you do on a daily basis? But these are our best frontline practitioners. And they're people who, when a person walks in and sits down in front of them, and this person, the patient that they intend to treat, they're actually blue with pink spots. And quite quickly, the clinician has blue with pink spots. And they're talking to them very deeply and understand them terrifically. Next person walks in, and they're black with orange spots. And the clinician becomes black with orange spots, really deeply communicating. It's these frontline practitioners who have gold of how you can, in their particular context, deeply engage and work for solutions. They have the innovation. It's the local wisdom. So when we then challenge this group of the best frontline practitioners and managers in the room using and considering their data, we ask them, well, 50% of the people coming to your service have a health literacy needs profile like this. In what ways does your organisation meet these needs? And we get told what they're doing or not doing in response at the organisational level. So we get all kinds of innovations across our 9 organisations about how to generate solutions. So one organisation is doing something in the same context, down the road someone else is doing something different. Whoa, you're doing that? That's interesting. We don't do that. It's the same patient population as us. We're doing this really silly, expensive thing for not many of our clients. First time they've ever seen their own patient data organised like this, and this is profoundly engaging and really simple to do. So then, here is one of the dimensions. Of first, we're thematically analysing all these great ideas that are coming from the front line, and there's sub-themes as well. Then we can look at the international literature to see, well, is there an evidence base for these particular ideas coming up? A lot of groups are already doing things like teach back and things like that. But some groups are doing teach back differently. Some groups have thought about, right, you do teach back, and what happens if the person can't teach back? Then what? But then there's all these native techniques in the field that people are doing because they care about their patients so much. They've seen so many people live and die and get well again, and they just reveal their tacit knowledge. So as we go through a whole range of these things across the 9 dimensions, we're getting a whole compendium of ideas on solutions that are context specific. So across many practitioners and organisations, we're getting lots of ideas and they're organised. We ask about individual characteristics and organisational characteristics. We thematically analyse identification of the mechanisms by which the interventions might work, and then identification of provider, organisational and higher order requirements. In this, we're able to build systematically a health literacy response framework. So we're building with these 9 dimensions, what can we do at the individual client level? Individual from the characteristics of the HLQ, the health literacy questionnaire, but all individual, the different kinds of clients coming to organisations. This is also revealing great details of what can we do at the practitioner level in many, many ways, many kinds of solutions the practitioner can do to be supported, trained, supported on going up, organisational level, and also the interagency level or the state level. We're doing a whole set of other characteristics about what's happening at many organisations, about what are they doing, what magic are they doing in their particular context. It's important I try to make this a little bit more grounded. What are organisations doing? What are they picking up? So we're doing this in the context of building a method. So it's not directly straightforward because the organisations are choosing their problem areas. They're choosing what is the patient groups which have a health literacy cause or an equity cause or something which is amenable to change. They're thinking about that, priority areas where they get impact on. They're choosing that. They're doing this health literacy assessment questionnaire, and just before coming over here, our 9 organisations presented at one of our group forums, and managers getting up or junior staff, well, when we did assessment of our patients, we found that they had this particular kind of health literacy deficit and this one. Therefore, our intervention is based on these mechanisms, and here's what our intervention looks like. They're saying things like one group's built a client screening preferences. Another group's a video education they're doing. Another group screened for client GP engagement issues. And these are organisations from municipalities to the hospital to community health. A huge range of organisations from city and country, many different contexts, so we can get a full range of kinds of issues to put in the compendium. Many other things, a health literacy policy. So it's not just the individual interventions, there's a policy being built by an organisation. Another group are really building a volunteer. The Country Women's Association, one group has decided they've got these volunteers go and chat with people about working better with your doctor. And of their own volition, they're building, hopefully, a model of their own volition that other Country Women's Associations around the country can do. It seems that we're giving these organisations permission to innovate. A small amount of money, $5,000, to come to our meetings, backfill, and time to share their daily knowledge, and they're given permission to innovate. A lot of these people are working in cupboards, under great duress in all these contexts, and doing great things. We're just providing an opportunity for them to share what they're doing. And there's great leadership happening with these organisations, wanting to share with the other 9, and then to build. They realise this is being built for their state. I organised for our Minister for Health to launch Ophelia, so they could be aware this is something bigger, this is something important. And on goes the list of potential interventions. Now, there's really important things to consider here about working with frontline practitioners. They have years of experience and tacit knowledge, and they're really important resources. We can't forget about them. They have deep knowledge of local situations, deep knowledge of the people we seek to help, able to respond to issues that are not covered in the published research, likely to be implementable. You don't need to try to convince people that it's a good idea once the innovation is developed. It's their idea. They're so proud, and it actually works because they do it every day, and they're really proud to see other people taking on their innovation in a setting. So we must not underestimate the value and power of local wisdom in local and regional and national reform, is our assertion. So to try to make this work, it's a bit like we're trying to develop a wiki. So in different contexts, people can get their own data, upload their HLK results, find out an organisation like me, and then see what other innovations have people done with challenging patient areas like this. So they can then see stories and narratives about how people like them, managers and clinicians, have solved problems. Narratives about how it works, why it works, in ordinary language, not academic speak. So toolkit, step by step, to make this happen. WHO have supported us to develop a toolkit for low and middle income countries using this kind of model. What I've described to you is a basic, fundamental, it's been done before in many sort of settings, about community development model. Local wisdom for local solutions in very different contexts. So this is my dream. This is almost my last slide. So my dream is that all interventions are developed based on identified health literacy need, if you will. The implementation strategy is thought through before the design starts. What I would love to have is interventions, the implementation is proven before expensive RCTs, co-created with end users. End users include patients, health professionals, managers and policymakers. It's fit for purpose and it's sucked into practice. That's what we seek. We can't find a better word for sucked. No one knows it's there is what we're aiming for. At the end of the program, it's their program. At our first meeting with our sites, I say, this is the last meeting I'm chairing. Because this program's for you, for your clients. It's about your organisation. It's not to do with me. This, you're part of, this is for you. And there's pride. They take this on. It's very exciting. All right, so everyone knows the 3 steps for implementation. This is a test for you, Tricia Greenhalgh. 3 steps, everyone knows them? All right, program design, scaled up, the middle step. Yeah, that's what most people think, isn't it? But it's already embedded and owned at the start of it by the way we consult. We seek to have the full range of needs identified. We seek to have it embedded in the system. Planned, structured, resourced and co-created for success is what we seek. So indeed you can have increasing implementation success over here. You can have massive organisational barriers. But when you have high need for innovation and high readiness for change, you can make it happen. When you've got very little obvious benefit from the innovation, it's not going to go anywhere. But when the innovation is so good it gets sucked into practice, you can get things completely routinized and in there. And that's what we seek to do. Thank you.